Welcome everybody to tonight's webinar. I'd like to begin by acknowledging the traditional owners and custodians of the lands and waterways from which we are all zooming in from today. We recognise their diversity, resilience and the ongoing place that First Peoples hold in our communities. We pay our respects to the elders, both past and present, and I wish to extend that respect to any First Nations people connecting in today. We commit to working together in the spirit of mutual understanding, respect and reconciliation. We support self-determination for First Nations, and ongoing organisations will work together on closing the gap. So welcome again. My name's Helene, and alongside me in the background is my colleague Jade, and we are the Workforce Development Officers at PHN. Just a little bit of housekeeping before we start. The majority of our webinars events are recorded and are available on our YouTube channel. Jade has that up on the screen at the moment. I have our upcoming events on the screen, but the major one we would like to highlight is our annual Primary Care Refresher Conference. The program has been uploaded in the handout section. Please make note of the Westvic PHN Health Pathways relating to this topic that is on the screen. And for this evening's meeting, you'll all be put on mute. And should you have any questions, could you please type them in the questions box and I will answer them on your behalf at the end of the talk tonight. They will be all answered anonymously. So our speakers for this evening are Dr. Alex Chen, who's a neurologist at Barwon Neurology, and alongside him is Brendan Cutts, who's a vestibular physiotherapist at the Neurological Physiotherapy Geelong. So I will now hand over to Alex to commence the presentation. Thanks, Alex.
Thanks, Helene. So I'll just there we go. So I'll just begin as noted by with the acknowledgement is there, and we'll just begin with a few outline and in general, first of all, defining what a vestibular migraine might be, along with some of the diagnostic criteria, and talk briefly about the role of medications, as well as the role of the neurologist and the physiotherapist. Brendan will go further down on the last 3 points in general. So I'll probably just begin a quote from my registrar days, where some of the major complaints that we do see are generally related to dizziness. And it is true that it can be some of the most challenging presentations that we see, but certainly I hope with some anecdotes and then some understanding of the nature of the things that we'll probably have a better understanding of this, of how to approach it. So perhaps I will describe briefly about what vestibular migraine is. And now we're probably going back to the good old days. This is a manual by Edward Living in the 1800s, where migraine was called migraine. And what is noticeable in those groups of times, people do suffer from migraines, and it is well documented in those groups in that pages that giddiness and vertigo is a common complaint and it's a part of the migraine experience. In the literature, we probably see vestibular migraine by itself ranging from 1 to 5%. And in most migraineurs, most of them do complain of vestibular symptoms. So any remote history of migraines or any history of migraine by itself, you see around a third to a fifth of them who have them. And the episodes are fairly variable, can be of many different types, but most of the time the description is of an episodic nature and often occurs spontaneously. Usually it occurs in a realm of 5 minutes to the realm of days. There are other variants as well, which is described as positional in nature. And the most common thing is that it usually tends to be worse on coming up versus coming down. the other aspect to mention about it, and this is where it can confound things, is that it is an approximately around 40% of patients. Often people do experience symptoms of fullness and tinnitus as well as part of their experience. So this can sometimes confound the picture, and we just have to be aware that this symptomatology can be a part of the experience as well, and we shouldn't cloud our diagnostic, or the more exact answer is to keep a much more open mind on this. In regards to the pathogenesis, vestibular migraine the pathophysiology is probably fairly similar to the pathophysiology on migraine. I've highlighted this diagram, but in sense of what they describe actually occurs in migraine. And how does it actually begin? We actually don't know. There are probably two main hypotheses, and one of them suggests that it begins in the trigeminal ganglion. For some reason, the trigeminal ganglion becomes more sensitized, and it then sends signals to the second order neurons seen within the brainstem, and it then moves further upwards, involving widespread cortical networks. The other hypothesis is that perhaps it begins in the cortical networks, and for some reason it feeds back to the trigeminal ganglion and exacerbates pain from there. Regardless, I think migraine, the simplest way I would say is migraines is an experience, and perhaps due to dysfunction of the cortical networks, it affects how we process the sensation of space and posture. And from there, it affects how we perceive things, and that leads to vestibular dysfunction and a sensation of dizziness and suffering. The most common criteria that we probably follow in regards to vestibular migraine are the criteria that is noted in the ICHD tree. And this, I would say we don't have to follow this exactly black and white. This is a guide really to help us to decide what are the actual symptoms of vestibular migraine will look like. And my only caveat with that is that these criteria developed by ICHD are predominantly research driven, so that there is an inter-examiner agreement. Whereas if you're in the front lines, it is often not how it would look like. Just by general experience, and I think the Barani Society has made an exception for that, is that some patients don't necessarily have headaches or migraine history, and you can see that outlined as under the probable vestibular migraine subgroup. And as I mentioned earlier, there are some groups of vestibular migraine that exist as positional vertigo, and this is quite a common things that we do see, but it again is not accounted in the criteria, and we'll probably so let's just be mindful that you have that criteria as a reference point, but in clinical scenarios sometimes you won't see it as such. What I would probably suggest then, from a general practice and from a physician point of view, is that we, rather than lumping everything as dizziness, there's probably a good, useful way of trying to understand the history. And from there, you can probably work it out what are the potential diagnoses, and then from there you can work it out what's going to kill the patient, or what's going to cause significant, severe, irreversible disability, or what can we have the opportunity to watch and wait, or what we can treat based on what's the most likely thing empirically. So on this basis, I find the description by Newman Toker to be quite useful, and really just tries to divide any patient who presents with dizziness. You try and divide them into 4 main categories, and that is either an acute continuous dizzy episode. The mainstay goes on the whether is it continuous or episodic, or whether it's postural or spontaneous. I think that in general, if you can work on those 2 axes, most of the time you are able to safely categorize it to a certain subgroup. The only other thing to be mindful of in regards to triggers are that some aspects where there are some special narrative, like if someone has dizziness when they are exerting themselves, you have to consider whether there are other alternative diagnosis, or if someone, say, just recently came out of hospital and they were on gentamicin, they are at risk of bilateral vestibular failure. So there are just some special narratives there that you would consider to be as part of your differential diagnosis. In general, most patients with vestibular migraine will either fit into either an acute continuous episode, or which you often see in emergency, or perhaps in a general practice, you probably see them more either as episodic continuous dizziness or postural episodic dizziness. And that's just something to be mindful for. So as I mentioned, I think these are generally iterations of what of the previous slide. But I think the only other thing I want to mention is when you make a distinction, there was a myth in the past where you try and decide whether is it pre-syncopal sounding or is it vertiginous sounding, and I've often found it to be not too helpful in that regard. And generally, what happens when you do that is that it closes your mind to further diagnostic possibilities, and it can often lead you to a wrong conclusion. And I think this chap, he did in his study, what he showed is that he had around 200 participants in an ED presenting with dizziness, and what he's found is he took their history the first time and they said, yes, this is vertigo, and then he came back again an hour later and asked them, so what was the symptoms? And 50% of them said something else that's not vertigo. So evidently the patient narrative can change significantly. So try not to be pigeonholed when you're taking that history. The other aspect, as we mentioned, is very useful. Is it postural? Is it positional? Is it constant or is it intermittent? And sometimes it's worth actually being very frank with the patient and just say, look, do you think this is there all the time, or are there periods where you're completely normal? Because sometimes it can be difficult, especially if a patient can meander to try and get to the point of this, and it's understandable. Some patients, it can be quite difficult for them to express themselves. So sometimes we just got to be black and white, especially in this, after they've given their narrative. And another tip I found quite useful, especially because that I tend to use that 5-minute rule just to kind of get the sense that is this the mainstay why I want to give this is If it's 1 minute, in general, it's probably a very short transient disorder, and it can sit within the BPV family, or can sit within the cardiac arrhythmia family, or can sit within the postural hypotension family. And often that 1 minute and 5 minute can be very vague for patients. And the general thing, when you do this thing, you just tell them, if I'm going to say 5 minutes or 10 minutes, which one is it? If I'm going to say it's 1 minute or 5 minutes, which one is it? And patients usually are pretty good at telling you then, well, no, actually, I think it's more 1 minute. And hopefully that brings you to the right pathway from there. And finally, of course, the extra additional symptoms where you ask these questions. I hope that just gives you a brief aspects about how we partake in the history of vestibular migraine. In regards to the role of imaging, look, most of the time, the vestibular migraine is a clinical diagnosis. And if you see enough of it and you hear enough of the stories, most of the time you're fairly comfortable to either make it either a definite diagnosis or a probable diagnosis, and you can act on that empirically. The general rule of imaging and tests is really to rule out other mimics of vestibular migraine, and generally some red flags are useful if they've got headache that is associated with immunocompromise, or headaches that is sudden or thunderclap in nature. So those aspects, often that's when you require imaging. Then there are aspects where people are dizzy and have progressive hearing loss, and again, imaging is useful because you need to rule out any space-occupying lesion. And of course, if there are clinical signs that may suggest involvement on the long tracks. I put first onset episode because, especially if they're history naive or they don't have anything in particular, because in those groups of people, often you want to establish that there isn't really anything wrong, and then from there you can work it out, that you've ruled out most of the dangerous or life-altering disease or trajectory. Now, in regards to management in general, look, I don't think I've got anything really special really to say, short of number one, actually taking the history and being familiar enough with the narrative, and then enacting the plan. The medications in general it's a there's often a multidisciplinary approach. It's a multimodal, holistic approach. And there isn't any special medication. You just treat it as how you would treat a migraine, a general patient with either episodic or chronic migraine. And again, the decision on whether you put them on a prophylactic agent is dependent on whether you would classify as very rare few episodes or whether they have a constant daily episode. We will elaborate a bit more on the medication a bit later. The other aspect is non-pharmacological arm, and Brandon will discuss a bit more about that side, but often it, again, as described, multimodal, holistic, exercise, sleep, dietary, stress, many others of that nature. Perhaps I'll probably go with ablatives, and I mean, I'm sure has been a lot of experience in this, given you, a lot of you are on the front lines on this. And at the very least, we're no longer using tamping, which is what in the classical ages, this is a skull of a person who suffered from headaches in the past, and the treatment in those days was to punch a hole in their skull, and hopefully we're way, way away from that side of things. In general, if in my practice, if I have a patient with either vestibular migraine or chronic migraine, often it's quite useful to sit down with them, just like asthma, to consider what is an action plan for them, and to provide written action plan for them to follow through. And look, this is generally we either use paracetamol or non-steroidal such as aspirin or anti-inflammatory. My favorite go-to is usually 300 to 900. That's just by convention from my side. And triptans. I try to avoid too much. I do consult them very early on medication overuse headache, because it's a problem if they continue. Generally, if they use more than 7 days out of 30 days of triptans, that increases the risk of medication overuse. I try to avoid opiates like Panadine Forte or any of the endone, because again that dramatically increases the risk of medication overuse. So I consult them very early on that basis, and I mentioned that generally I just tell them, reserve this for your really, really bad days, or you got to perform in a certain part of your work, and just budget it. So you keep it to 7 hours 30 if at all possible. In vertigo, sometimes you're lucky enough, if you treat the headache, the vertigo gets better. But there are some groups of people where the vertigo occurs exclusively on its own. And in those groups of people, you often add either Stametil or ondansetron. And very rarely, if you have they have significant debilitating vertigo, I do sometimes relent to a bit of benzodiazepine, but preferably you would let me be involved, or at least let the neurologist be involved if you were to make that decision. In regards to migraine prophylactics, so there are the general rule for chronic migraine management is that if you are having more than 4 event days in a month, or you are significantly disabled based on your the MIDA score, it is probably quite reasonable to be on a migraine prophylactic. In regards, is there anything special for vestibular migraine? Answer to that is normally no. There are limited clinical trials that test for those too. And invariably it involves what you're going to choose. Invariably it involves a lot of negotiation and a lot of follow through with patient to know that you're not just prescribing a regimen and they're not follow and letting them be. But in general, I list it out there in that sense, and just probably a few mentions that I would do is in regards to venlafaxine. There are some small data that some people suggest if they have a lot of visual induced vertigo, or if they have what we call 3PD disease, which Brandon will mention a bit more about that. There are some anecdotal data that venlafaxine perhaps is much better on those groups of people. So really, it's about just tailoring it to their patient using with the migraine prophylactic. The only other aspect I would say as part of migraine management to be involved is to actually give them a lot of the patient a lot of information, and I've listed some websites there for you. If you could read up, the patient can read up on your own, and they get engaged, or they get more empowered to manage your own condition. And I generally find that patients have a much more positive experience, or they are more the more engaged they are, more workable they are in trying to get things better for themselves. So just some things in there. I think I'm probably going to Brandon on this side, so I'll pass on that to you.
Thanks, Alex. So I'm going to touch on some of the self-management strategies, non-pharmacological self-management strategies. So to start with exercise, we can see we've had a systematic review of 6 papers, which was pretty limited by the heterogeneity, but it found a reduction in migraine days with regular aerobic exercise outdoors, key being outdoors. As far as weight control goes, there were 2 retrospective studies that have shown that weight loss and surgery have been effective. But as far as RCT goes, the only one that I could found that a calorie-restricted diet along with moderate intensity exercise was equivalent to migraine education for 16 weeks. Sorry. So the anecdotal evidence is there, but as far as something stronger, it's still on its way. Diet has been studied a whole lot more. Oops, sorry. So as far as water intake goes, obviously aiming for 2 litres, which is a pretty standard goal for most people. Having regular small meals can be another target as well, to try and iron out any ups and downs in someone's blood sugar level. The only caveat with that is that sometimes people's method of snacking means they end up having a higher salt or fat intake, which are 2 things that have been shown to potentially increase migraine risk. So encouraging people to increase or have their snacks as fruit or vegetables would be the way around that. Observational studies have shown that lower consumptions of fried foods and processed meats, soft drinks have all helped as well. But the salt intake has both had evidence for and against changing salt intake. Sleep is something that has a lot of evidence for an improvement in sleep hygiene can make a big difference to your migraine risk or the ability to trigger a migraine. Wind down time refers to trying to limit screen time and reading and exercise in the hour before bed, or even 2 hours. Trying to establish a regular routine where you both go to sleep and wake up at the same time each day can help, as well as avoiding things that are going to trigger a full bladder for you. So avoiding caffeine, alcohol, and even avoiding fluids after dinner. Try and keep the bed for sleep and intimacy would be another piece of advice, because 2 days of lowered stress and adequate sleep is a significant protective factor against headache and similarly to migraine. As far as stress goes, patients need to be able to identify that they're stressed and be aware of what personally helps them de-stress. Relaxation strategies are vital to try and reverse stressful periods, and developing time management strategies can prevent stress in the first place. Many people find they're getting stressed because of the unpredictable needs of people that they're caring for as well. So some dedicated time where they can look after themselves can make a big difference, even if it's just for a few minutes. So often prioritising themselves is a big deal. Possible triggers are pretty varied. In order of likelihood, the hormonal changes, the key there for women with menstruation and menopause, stress, lack of sleep, physical or mental fatigue, overstimulation, which is typically things like being in a busy or unfamiliar environment, being, watching a movie, being in a crowded supermarket, and bright light. Car travel, which includes both being a driver or a passenger. Some people find that they can tolerate one and not the other. Fast head and body movements, so that may be standing up really quickly or bending down. They're typically the fastest movements people do, but they may find that, say, they were turning around, they span around in the kitchen quickly to check on something, and that's what triggered things from there. Neck stiffness and pain, changes in altitude, changes in weather, certain foods and drinks, as well as skipping meals is another trigger. Probably also worth mentioning that we've seen many people present with what seemed to be their first vestibular migraine after either the COVID vaccine or after COVID as well, but that has less published about it. Some common dietary triggers, alcohol, including both heavy consumption. Most people know about the association of red wine, cheese, chocolate and citrus. All together they tend to go as a bunch. And regular alcohol consumption is another common trigger. Chocolate, caffeine consumption and caffeine withdrawal. So it's common for us to recommend that someone reduces their caffeine intake, but if they go from 5 coffees a day down to 1 really suddenly, then that can also trigger things. So it's essential to do it slowly. Citrus fruits, tomatoes, onions, high fats. Again, high baseline consumption increases the frequency of migraines. Dehydration, processed meats, MSG, and the key one is skipping a meal. When to refer onwards, so I'll speak on Alex's behalf here that any uncertainty in the diagnosis or persistence in spite of treatment would be a key reason to refer on to neurology. As far as vestibular physio goes, we'll expand a bit more in the coming slides, but any head motion based dizziness or visual motion induced dizziness where things are moving across vision. The physio can also assess for other causes of dizziness, as well as manage secondary sequelae like neck stiffness and other things that we'll cover soon. So these are some of the more common conditions related vestibular conditions. We're going to cover the top 4 in a lot more detail at the moment. But as far as stroke goes, obviously you can give similar central findings as to what a migraine might, but it shouldn't be recurrent, and the onset should be more sudden, but certainly for some vesicular strokes, they have a kind of a stop-start process in the way that they come on, and sometimes migraine hits people pretty suddenly too, so it can be difficult to actually provide a distinction. For vestibular schwannoma, that can be irritative for the vestibular cochlear nerve, so raise the likelihood of having a migraine. I've certainly seen a few people that have got known schwannomas that are just being monitored who are actually more bothered by migrainous symptoms. Vestibular paroxysmia is a condition also commonly called neurovascular compression syndrome. They're brief, frequent attacks of dizziness, usually seconds, but can last up to a minute or more. Attacks of dizziness and oral changes sometimes as well. And this is due to compression or irritation of the vestibular cochlear nerve and can be either spontaneous or positional. So there is a bit of crossover with migraine, but the time, the temporal changes are the main thing. So with paroxysmia, it really is very, very brief, whereas migraine is, according to the diagnostic criteria, 5 minutes through to 72 hours, but typically you see people have it for hours at a minimum. And finally, glioma can also be irritative for the central vestibular system and lower migraine threshold. I've just included this recurrent vestibular symptoms, not otherwise specified diagnosis, which is kind of the bucket for everyone else that doesn't neatly fit into any of the criteria. There might be someone with, say, 20 minutes of episodic dizziness that comes on fairly frequently, that seems to have triggers like migraine but has no migraine symptoms. These are the people that may have migraine, they might have another condition, but we need to keep investigating or keep treating to see if what we do changes anything. Just going to cover some anatomy now. So the vestibular system has a few roles, including ensuring that your eyes stay on a target while your head moves around and assisting with upright posture and balance. You've got a pair of apparatus that are fairly parallel to each other. You've got 3 semicircular canals that are blocked off at one end, and they're responsive to changes in acceleration. They're oriented so that no matter how you move your head, you're always going to stimulate at least one of them. Up the top here, we can see that, I'm not sure if you can see my mouse, but the blue underneath the spinning lady, you can see that there's a blue bulb, which is the cupula. Inside, this is the ampulla, the end of the canal. It's slightly incorrect in that the bulb, the cupula, never actually moves away inside the ampulla, but it will billow like a sail, like a spinnaker, which is how it stimulates the hair cells in it. Then you've got the 2 otoliths, the utricle and sacule, that are connected. They detect horizontal and vertical motion. And to make sure that they're extra sensitive to gravity, they've got their little nerve endings sitting inside a jelly layer, which you can see down on the bottom picture on the left side of the screen. And to make sure they're really responsive to gravity, they've got otoconia, this crystal structure sitting on top of them that adds weight to any movement, so that they will enhance the nerve response. So in BPV, the otoconia from the utricle can fall into the open end of one of the canals, and it typically falls into the posterior canal because that's downmost when people are asleep. And so that's by far the most common canal. This is responsible for about 90% of BPV, but it is possible to have other canals affected too. This is a mechanical issue, so the patient will only get their spinning dizziness when they're moving in the plane of the canal, which is usually things like rolling over, laying down in bed, or looking up into a high cupboard, or pegging out things on a clothesline. But otherwise, they won't feel too bad. So sometimes they feel fine walking around, or they might feel just a little bit unsteady, but if you lay them down, they get this intense spinning sensation. To resolve it, the particle needs to be tipped out, which is the role of the Epley maneuver. And I might just mention that Brandt-Durrell exercises don't actually tip the particle out, they just slowly help the patient get used to it. So this is a different talk, but 1 Epley is equivalent to 10 days worth of 3 times daily Brandt-Durrell exercises. So, and is much nicer for the patient. So definitely in favour of an Epley. So I mentioned Menieres disease next. In this case, you've got increased pressure inside the membrane that initially irritates the vestibular system, and then over about 30 minutes is thought to rupture the membrane between the perilymph and endolymph, which causes a non-functioning labyrinth that then will resolve over the next 6 to 12 hours. And for that reason, the patient gets both vestibular symptoms and oral symptoms. They'll have tinnitus and loss of hearing, particularly low frequency hearing loss, at the same time as their dizziness. Now, unfortunately, they can also get headache and other things at the same time that will mimic migraine. So teasing those 2 out can be a bit of a challenge. And then finally, I mentioned vestibular neuritis. So this will be one or both of the nerves coming from the vestibular system. There's 2. And it's usually due to a virus, most commonly the herpes virus, but there have been links to most common viruses. So say the patient could have had a cold in the week before and then they developed dizziness. The main issue here is that the neurovascular bundle runs through a really narrow canal, and so there is potential for the inflamed nerve to compress the artery it runs with and infarct the region that it supplies. So for this reason, only about 50% of patients will get recovery of the nerve. Steroids inside the first 24 to 48 hours give the best chance of neural recovery, and physio can help with the rest. Now, peripheral dysfunction is important because there's around 25% prevalence of vestibular abnormalities or peripheral dysfunction in people with migraine, and those people are 5 times more likely to be dependent on prophylactic medication after 6 months. So it makes a big difference to their outcomes. It's not entirely clear why they might have the peripheral dysfunction. Could be because of migraine-induced ischemia of the inner ear, vasospasm of the internal auditory artery. Could also cause vestibular hyperfunction and vestibular migraine, or there might just be inflammation of the labyrinth that leads to scarring over time. BPV and migraine commonly coexist. They're the 2 most common vestibular conditions. BPV is the most common peripheral and migraine is the most common central. There's a 2-fold increase in the incidence of BPV in migraineurs in general. Positional nystagmus is also present in around 50% of vestibular migraineurs as well, or during 50% of vestibular migraines. So where BPV typically has a brief latency before crescendoing to a large amplitude rapid nystagmus and then decrescendoing down, migraine nystagmus tends to be more vertical or pure torsional or horizontal. BPV nystagmus will always be in the plane of the affected canal. So in the posterior canal that sits off the back of your head, that's going to be that movement. So we typically see it turning up and around. Whereas the migraine nystagmus will be lower latency or no latency, much lower velocity and more persistent, not necessarily in the plane of the canal. Just want to run over the criteria for Menieres disease. There was once a time where I think most people ended up with a diagnosis of Menieres disease if they had episodic vertigo. But the criteria set out by the Barwon Society in 2015 have tried to lock it down to patients that have had 2 or more spontaneous episodes of vertigo lasting 20 minutes through to 12 hours. We've also got documented low to medium frequency sensory neural hearing loss and fluctuating oral symptoms in the affected ear through that time. So they should be able to localize it to one ear being responsible for all of their symptoms. And it should be briefer than 12 hours. And that's usually the defining feature of difference between Menieres disease and migraine. Also worth mentioning that Menieres usually will come on between the 3rd and 7th decades of life, which can be different to migraine. It's also associated with several comorbid diseases such as arthritis, psoriasis, reflux, irritable bowel, and migraine, unfortunately. So where the 2 are similar and different, there's definitely a female preponderance in migraine, whereas it's fairly similar for Menieres disease. Migrainous symptoms can be present for both and absent for both. Oral symptoms are usually more prevalent in Menieres disease, but can be missing, particularly in the early stages of Menieres. The dizziness may not be present, even though the hearing changes are. But over time, as the labyrinth gets scarred, that can reverse and there may not be much of a change in either of the dizziness or hearing, depending on what actually happens and what goes on. Again, because Menieres affects one ear, they really should have high velocity nystagmus, horizontal beating towards the healthy ear. whereas migraine can give you spontaneous positional or head motion induced vertigo and or nystagmus as well. The nystagmus is usually low velocity, and any pattern really is possible. The other hard thing is that patients can have both, but they may be able to decide or describe two different phenomena that they experience. This is 3PD, persistent postural perceptual dizziness. Alex touched on earlier. This is it tends to happen in the person who dwells or worries over things as well. And in general is a normal physiological reaction to strong dizziness or disequilibrium. So normally we would activate alternate and additional systems of movement control, such as keeping your hands out, widening your base of support, lowering your center of mass, like when you're walking on ice, that don't rely on vestibular information when you have a significant dizzy event. But once that acute trigger has subsided in 3PD, instead of returning to normal function, a vicious cycle of maladaption can arise, which is driven in part by excessive self-observation and anxiety. Somatosensory information about body's position can then be amplified and distorted, which in turn produces subjective dizziness and leaves movement control on red alert. Secondary effects like stiffening of gait, phobic avoidance and mental fatigue can develop. So the aim of therapy is to readapt the system to normal function by reducing anxiety and self-monitoring, habituating to provoking factors and promoting automatic movement control until recovery is achieved. So having both conditions, an episodic condition in migraine, providing regular provocation, can make readaptation towards normal function very challenging for the patient. So the role of vestibular physio is assessment and diagnosis of dizziness conditions, as there may be multiple. Education of the patient, so focus on self-management strategies, therapy options, and the role of medication. Liaison with their GP. Vestibular rehab, which can be head motion or visual motion induced dizziness or dizziness imbalance. We often have a very cautious approach because sometimes these patients can be quite irritable with their dizziness. We'll also want to manage the secondary sequelae, such as fear avoidance of certain tasks, neck stiffness from the head being held still, any expectations of dizziness exacerbating true dizziness. Patients can also be quite agoraphobic and can also co-present with functional gait disorders as well. Just mention some other resources as well. So we've got two devices at the top there, the Kefali and the GammaCore. Kefali is a self-adhesive electrode that uses electronic stimulation to target the ophthalmic branch of the trigeminal nerve, which can be responsible for migraine pain. They've got a 60-minute daily treatment, a 60-minute acute treatment, 20-minute daily prophylactic treatment. They're fairly expensive. They're $400 or $400 to $600, depending if you get them on sale. And you need to keep purchasing new electrodes as well. But a double-blind randomized sham-controlled trial did show that the Kefali reduced total headache days and headache frequency, but not severity, with almost 40% of participants responding to it. The GammaCore is a non-invasive vagus nerve stimulator. It's also been shown to be effective for migraine ablation. It's got a similar cost to the Kefali and requires multiple short treatments in a day. It's only got about a 20% responder rate. There are a couple of other non-invasive and invasive devices that have been developed, but they have less study or less research completed on them. These FL41 glasses or lenses, it's a coating on lenses you can get that blocks out blue light. Patients often find them very helpful if they've got photophobia or eye strain associated with using screens or some overhead lighting. They do make indoor and outdoor versions. The lenses themselves are $100 to $150, but the patient may need to ship them from somewhere around Australia or even overseas to get them, so they can end up being quite expensive. And I'll also mention behavioural optometry as well, where they will have other measurements of the eye's ability to track and change focal lengths and function, both separately and as a unit, which the visual changes like that can certainly be a migraine trigger for patients or make their dizziness persist. Just mentioned the Barwon Health Vestibular Assessment Service. So this is expert assessment by a Vestibular Physio and Vestibular Audiologist at the Menieres Centre with a full suite of vestibular function tests. We're able to escalate care to ENT if required and provide a report back to the GP or referrer regarding the assessment. Ongoing therapy at the Menieres Centre, physio or audiology as needed is possible. It's a publicly funded service. This is what the referral form looks like, and you can just head to the Barwon Health website and look for audiology, where you'll see their referral forms. So as far as options for local physio, comparing the public versus private system, both will have an expert physio assessment. For public, looking at same-day audiology assessment when the patient is referred to the Menieres Centre, whereas by referral for private has a much shorter wait time. The public obviously has a free service versus paid for private, but patients can choose the days of week and after hours if they need to, and don't need a referral. We've got a few pages of references there and time for questions.
Okay, if you've got any questions, could you please type them in that questions box? I don't actually have any at the moment, so anything at all you want to ask the two presenters, please start typing and then I can answer them on your behalf. While we're waiting for some questions to come in, if any, thank you to our presenters for this evening. Fantastic presentation, very informative. If anyone's GPs have got their evaluations they need to fill them out, please. That'll come on the screen after the event. And if you've got any other vestibular topics or anything, please type them in for the topics requested, or any neurology, physio topics, please pop them in and we can sort some more events out for that. So just a comment, thank you for your time and knowledge, much appreciated, coming from one of the audience. Just give it another couple of minutes to see if either of you got any more comments that you want to make, Dr. Chen or Brendan?
The only comment I have to say is that this is not something you're going to learn very quickly in just in an hour. This is mostly to provide a framework. What I do find is that article by Newman Talker, The Symptoms and Signs, that's actually quite a useful narrative. So it starts you in a good narrative and how you would take a history through dizziness. And if you know some diagnosis, there's only a few conditions you can fit into it. You can, with that, you can just say, look, I can try this, this, or this. At least I've already got it started already, and at least I've got some baseline or framework to work with the patient, rather than saying it's vertigo, it's vertigo. Okay.
A couple of questions. First one, what is the recommended timing for commencing vestibular rehab for vestibular migraine? i.e., should you wait until attacks are under control before commencing the rehab program?
I'd say it depends. For patients that are having quite significant symptoms or are really irritable, then often we won't do any, I guess, typical vestibular rehab exercises like lots of head turns or lots of visual motion confrontation to them. But often they will get a lot out of the education side of things as a starting point. So I've definitely seen plenty of people that have responded quite well just to the education that we've done, even if we've delayed the therapy. That being said, there's definitely a group of patients that do better by waiting when we start rehab, and for some people, I'll meet them for the first time and recommend they go back to their GP, and I'll write a letter back to their GP to have a chat about whether medication would be appropriate for them before we consider vestib rehab. So yes, it does depend. I think how irritable the patient is in front of you and how easily their migraines are triggered and their dizziness is triggered is mostly the thing that separates it.
Thank you. Question for Alex. Do you think in the first instance patients should be referred to GPs for medical management or neurology?
To be honest, if you feel comfortable with the history in regards to if there is the dizziness sounds is associated with every time they have that migraine, and if you're comfortable with migraine prophylactic and in regards to the negotiation with the patient in regards to that, perfectly comfortable for you to begin the therapy. If that works, then you may not need to see a neurologist, but if not, then always happy to help out. I'm not sure. It's not it's just, yeah, you could say yes, you could refer to all neurologists, but not enough resources, unfortunately, for that basis.
Thank you. Another question, can you elaborate on the role of steroids in vertibular neuritis?
So the role of that is, so the most important, what I normally tell my patients is, so most of the time you just need oral steroids. You don't need anything further beyond that. In the studies, what they have shown is that it probably shortens the time towards recovery. So it's a bit like Bell's palsy. It probably doesn't change too much the actual outcome. If the deficit is bad, it's bad. But using steroids for at least a 5-day course probably shortens the amount of time that they are severely disabled. But they still need ongoing vestibular rehabilitation so that they can develop a vestibular adaptation mechanism. And at the same time, they don't go on to develop other vestibular-related pathology, which is not uncommon. After vestibular neuritis, they can go on to develop vestibular migraine, 3PD, even BPV. So steroids only useful for the first 5 days, and then everything else, it's usually physiotherapy do a lot of legwork, really. Hope that answers your question.
Sorry, I was on mute. Is there an ideal time for trying Epley in BPV? That's another question come in.
You diagnose it, you do it. That's
straight
general
away.
rule. Yeah, straight away.
The only thing I would add is that if they're vomiting already, then antiemetics and then do it. But yeah, if you can get the patient through it, then you can do it straight away. Yeah.
Okay, that finishes our session. No more questions. Thank you both again very much, and thank you to all the participants for attending this evening. I'll now finish the webinar. Thanks, everyone.
Thank you.